Hello, everybody. My name's Ed Pavlik. I'm good. It's very good to be with you today to bring you a new Gynec Garage on today, which is World Penguin Day, believe it or not. My name's Ed Pavlik, and I'm in Lexington, Kentucky, where the blooms of spring are right here upon us. I feel that summer is coming, and that everything will turn out well. I'm on a roll today, so
Yeah.
you have to share what I mean with you. This is in fact what it looks like
Oh,
in Lexington, and it's very, very encouraging.
yeah.
So
Very nice. Yes.
so today I'm here with my compatriot and colleague and sensei, who is
Okay.
is willing to share some wisdom with you in both the
Yes.
Eastern and Western tradition.
Absolutely. Yes. Yes. That's
So,
I look like Mr. Miyagi out of the Karate Kid, I think.
absolutely, absolutely. Well, today we're going to consider a paper from the USC in LA, that's the University of Southern California, and also from Japan, that reports on the risks due to the manipulator during laparoscopic hysterectomy. This retrospective cohort was recently published in the International Journal of Gynecologic Oncology. Frank, take it from here. What's your take on this paper?
Okay. I, I, it's to some extent, this goes back to when I was a very junior doctor, and for an endometrial carcinoma hysterectomy, the surgeons would either sew up the vaginal cuff before doing the hysterectomy or insert a swab with mercuric chloride into the upper vagina, because the worry was that cells would be, during the hysterectomy, cancer cells would come through the cervix and seed themselves to the vault. Clearly, that's not the case. It's lymphovascular permeation or whatever else. And this, in a way, is a very similar sort of paper. The premise is that uterine manipulation, putting in a manipulator to move the uterus around to allow better access during laparoscopic procedure, in some way dislodges endometrial cancer cells and either seeds them into the lymphovascular system, or in some way they escape the uterus, presumably through the fallopian tubes, to produce positive cytology. The authors say that this is quite there is not an agreement, I think, as to whether or not this it occurs, and they cite five papers saying that the jury is really still out on this. Unfortunately, the papers that they cite actually don't come down on the influence of the manipulator on the positivity of LVSI or Washington's law. Only one of the five actually does that. However, these authors have looked at quite a number of patients, 1,200 in each arm, a retrospective study looking at lymphovascular space invasion, positive cytology, and 5-year survival in a group of patients that had laparoscopic hysterectomy without a manipulator and laparoscopic hysterectomy with a manipulator. And the data does seem to suggest that there is an increased risk of LVSI, positive cytology, and a decreased 5-year survival in the patients who have an intrauterine manipulator. What they don't, so the assumption that what they're trying to say is that there is a link between intrauterine manipulation and these adverse prognostic factors. But what they don't actually do, I think, particularly well, is say that one is the cause of the other. And there's a number of weaknesses, I think, in this study. One of them is that although preoperative imaging presumably were carried out, there are no data in the paper on preoperative imaging. So although the majority of them were GYN endometrial carcinomas, FIGO1, grade 1 or 2, we don't know whether these were in the polyp. We don't know whether or not these were in the uterine fundus or further down towards the cervix. We don't know when the peritoneal washings were taken. Were they taken at the beginning of the procedure before the manipulator was put in? Were they put afterwards? And I think that's actually quite a weakness of the study. We don't know whether or not the uterus was perforated during the procedures. So although there is in this paper, a link between intrauterine manipulation and adverse prognostic factors. I'm not sure that it actually takes us anywhere further than we already know. Interestingly, I was just doing some research and had a look at a paper. This is in the Annals of Surgical Oncology. They've Siegenthaler et al. From Bern, and they've actually done a slightly different thing. This is a prospective study, and they've looked at 3 sets of washings taken at the time of the insertion of the laparoscope, washings taken during the procedure with the manipulator, and washings taken after the procedure, to try to get some idea of whether or not it was the manipulator that was actually causing the positive washings. And the numbers aren't big, but out of 26 patients with positive washings, 16 were positive at the beginning of surgery, before the manipulator had been put into the uterus, which I think is quite interesting and clearly conflicts with the data from this Japanese American study that suggests that it's the manipulator that was the cause of the problem. The recurrence rates do, however, suggest that if there is, as we know, positive washings, then the recurrence rate, the prognosis is much worse. But that I don't think we've got a lot of data that says it's the manipulator per se that is the cause of the problem. And I think we're going to have to do more studies to do this. Perhaps one thing is that the fallopian tube should be ligated or in some way occluded before we do manipulation of the uterus in a laparoscopic hysterectomy for endometrial carcinoma. It's an interesting study. I don't think it is definitive in any way, and I still think that the jury remains out as to whether or not this is really a problem. But it's something that needs to be considered, I think.
Absolutely, Frank. I think one of the things that the reviewers probably liked about the paper was that if I can get this up and share it with you, you can see that group 8 is with the manipulator involving all the other risk factors, both the LVSI and the washings. And group 7, the manipulator is not involved. And there is a big survival drop-off when you throw in the manipulator. So what we're talking about is group 8 versus group 7. So I think really from that figure in the paper, the reviewers felt quite justified to accept it for publication. All that being said, they really don't have the a priori evidence about LVSI or contamination of the peritoneum with malignant cells. So the study you describe, I think, will go a long way into resolving that. Also sort of wonder too, if you start off, as you said, with malignant cells in the surgical field, when you're bumping around with the manipulator, to what extent are you, even though you're not causing a perforation, to what extent are you causing a weakness through which bacteria and tumor cells, could proceed?
Yeah.
So I mean, those are all factors. Well, go ahead.
I think this should encourage prospective studies. I think the weakness of the one that we've been discussing is it's retrospective, and I mean, was all the cytology reviewed centrally? All sorts of problems really in a retrospective study. And I think that the paper that I alluded to or discussed, where the numbers are small, but I think prospectively it wouldn't be difficult to get a large number of patients in a country where there are centralized or at least agreed ways of carrying out surgery, to do a good study, randomized study on those grounds. When does the cytology become positive? Is it positive at the beginning of the laparoscopy? Is it positive during the laparoscopy, or is it positive at the end? And I think that's quite important. So I'm sure in 2 or 3 years' time, if we're still here, we'll be discussing some very similar paper with possibly more data that we can understand and accept, and it'll change practice.
So the question you have to ask is, if a priori you have malignant cells in the surgical field, and you have an opportunity to push them to where they're going to be a problem further on, what steps should you anticipate? to minimize that. And I mean, it's one thing to bump into the tumor and to cause it to rupture and to cause that to be what's happening, but it's another thing for them to exist there a priori and maybe not do as complete a job in washing things out as might be needed.
Mm. Yes, I think also, I mean, certainly when I was carrying out laparoscopies for ovarian cancer, we would have the 4 quarters of the pelvis and abdomen where we would take washings. And we don't know it from this study. Was it just a single 10 mils of fluid? Was it ascites, or was it saline washings? And unfortunately, this study hasn't recorded, or if the data are there, they've not published it in the study. So we really don't know. It throws up a lot of interesting ideas, but I think the study is flawed because it's retrospective, really.
Absolutely. Well, Frank, we've done it again. We've covered another Gynonc Garage, and I look forward to doing this again with you next month.
Absolutely. See you then. Hope the weather gets better by that time.
I hope you warm up.
Thank you.